Welcome, everyone. And I know it's been a long day for many of you. Surgeons, urologists like to start their days very early. I started mine at 4 this morning, so I know how you feel. But thank you for being here tonight to discuss, I think, what's really exciting for our patients, that we've got so much more to offer. And we'll go through several things in a short amount of time. And hopefully it'll generate interest to go and look for more information and maybe more collaborations. So we named this Next Generation Treatment, Pathways in Prostate Cancer, Basic Practical Case-Driven Guidance to Individualized Care. So I'll present myself, Fred Saad. I'm a urologic oncologist from Montreal, from the University of Montreal. Half the world thinks I'm a medical oncologist because I do so much systemic treatment over the last 30 years, but I'm a urologist, and I do enjoy being in the operating room and having those exciting moments of getting a bladder out and reconstructing a new bladder. But the real challenge for me has been in advanced prostate cancer, and I've dedicated a lot of my time in the last 30 years on that. And I'm accompanied by, I think, one of the world leaders now in prostate cancer, Saad Barata, who is associate professor at Case Western University in Cleveland, soon to be, I hope, professor. I was asked to write his letter of recommendation, so we'll work on that, Pedro, very diligently. And thank you to Peer Review and Zero Prostate Cancer for providing this session, and a special thank you to Bayer and Blue Earth, who provided the educational grants for the symposium. But this was really hands-off. So what you're going to hear are what Pedro and myself put together that we think is relevant for urologists to know, whether they do it themselves or not. It's important for our patients to be aware of what we can offer. If you haven't already done so, can you complete the pre-event survey and look out for additional polls? And there are in-room learners, but there's also virtual learners that are going to be watching online. So if you haven't already done so, you can scan the QR code there on your table, and the more you interact and answer, the higher the likelihood of winning a prize from PeerView. And just in case you want to go back and get some of the data that we're presenting here and a lot of other data, you can go to the peerview.com website and get more information. So let's start with the first question. Which of the following represents a challenge to your treatment decision-making for patients with prostate cancer? And you can select all that apply. Understanding available and emerging intensified options, treatment sequencing considerations, providing patient education for available therapies, adverse event management, or awareness of clinical trial opportunities. And you can answer more than one, and then we'll briefly discuss and then go on to the content. That's your cue to vote. Okay, that's great. So we see that almost everything is of importance, and I share, even though I spend all my time in this area, I would share that all of these come up and are a challenge all the time. And just a shout out to Zero Prostate Cancer, where there's a huge amount of information when you're challenged with having to get patients involved. And patients really have to be involved, especially when we don't have a strict algorithm for treatment, and that's what we call shared decision-making. And it's throughout the continuum. For urologists, we have to discuss the options of radical prostatectomy, radiation therapy, active surveillance, and the patient has to be involved in that decision-making, and very much so through the spectrum of prostate cancer. So let me start off with a short overview in the systemic treatment of high-risk locally advanced prostate cancer, and I think everyone in this room would have encountered these kind of patients. And the first study that actually showed us that we can make a difference in intensifying therapy in patients who are non-metastatic. And this is important because we've known for a long time that we can do much better for metastatic patients. But here, these are high-risk, localized prostate cancer, and I added the word very high risk. So these are patients that clearly are at high risk of becoming metastatic and dying. And what the STAMPEDE trial showed us is that if you add an ARPI, and in this case it was abiraterone, you can significantly improve the time to metastases. You reduce that by 47% and reduce the risk of death by 40% by adding abiraterone plus or minus enzalutamide to ADT and radiation therapy for a fixed amount of time of 2 years. So this was really our first foray in that we can do better in these high-risk patients, and how we identify them is our challenge. And we've known for a long time that biochemical recurrence in prostate cancer, whether they had surgery and radiation therapy, or even radiation therapy alone, the short time it takes to become a recurrent, the doubling time of the PSA, and high Gleason score are predictive of early bad outcome. And what is always coming up as probably the number one cause of or risk of metastases and death is PSA doubling time. And the shorter the PSA doubling time, the higher risk of becoming metastatic and actually dying from prostate cancer. And one of the first large randomized studies to address whether intensification would make a difference is EMBARK, and I'm sure you've all heard of EMBARK, really basically taking patients recurring after surgery plus or minus radiation or radiation alone with doubling times of less than 9 months on conventional imaging being non-metastatic and randomized to enzalutamide with leuprolide, placebo plus leuprolide, or enzalutamide alone. And what the study showed is that enzalutamide with or without leuprolide significantly improves metastases-free survival. It's not surprising to me that adding enzalutamide to hormonal therapy would improve outcome, but I was actually surprised that an ARPI, in this case enzalutamide, and I would say they're all equally effective in terms of efficacy, that enzalutamide monotherapy actually beat out LHRH analog. However, in terms of overall survival, the study recently reported that there's a 40% risk reduction of death by adding enzalutamide to leuprolide over leuprolide alone. In terms of enzalutamide monotherapy, there was no advantage, but I would look at it positively. There was no disadvantage in terms of overall survival in patients that you think would be appropriate to treat with ARPI alone. And we can come back to that in the discussion. And now we have multiple phase 3 studies looking at these earlier settings of disease that are non-metastatic. And very soon you'll hear the results of Proteus, which is really a surgical trial of 2,500 patients randomized to getting apalutamide plus ADT versus placebo plus ADT in patients that are undergoing radical prostatectomy for high-risk, very high-risk prostate cancer. So that is going to be presented at ASCO in a couple of weeks. And then Atlas looking at intensification in patients going on to radiation therapy, so very similar to STAMPEDE, maybe not as high risk as STAMPEDE, but looking also at adding an ARPI to ADT and external beam radiation, and DAZEL HiCap, which is a huge study, also looking at very high-risk patients getting adjuvant therapy to improve outcome. And then you have ARASTEP and Primordium that are looking at this new area of PSMA-positive metastatic hormone-sensitive disease. Because in all the studies until now, to be considered metastatic, you had to be metastatic on conventional imaging. So we'll see how those trials pan out and change the way we view patients coming in with advanced disease. And this brings up the issue of imaging. You know, we've been using conventional imaging, CT, bone scan, for a very long time, and now we have this elephant in the room called PSMA PET. that is disruptive, but hopefully used properly is going to improve outcome of our patients, because we can detect earlier areas of recurrence, metastatic disease. We can potentially improve the outcome of these patients and maybe eventually be able to treat them adequately with less intensive treatment or a shorter amount of time using these types of imaging. And we've had gallium for a long time. PSMA 11 FDA approved in 2020, and then following that there was the F18 piflufolastat based on the Osprey and Condor trials approved in 2021, and the most recent F18 flotufolostat based on 2 trials got FDA approval in 2023, and here we're starting to try to refine PSMA imaging and try to get away from these backgrounds of the urinary tract coming to interfere and maybe sometimes make our imaging a little less easy to interpret. So these are radiopharmaceuticals, probably not your domain, but just to be aware that even the quality of the imaging based on these agents is continuing to improve. So let's go to a quick discussion in this patient who had a radical prostatectomy 6 years ago, 67 years old, so would be considered quite young, Gleason 8 disease, positive margins, node negative, unfortunately had biochemical recurrence 1 year after surgery and had salvage radiation therapy, but now is recurring again with a rising PSA that's up to 3.6. Doubling time is 6 months. And here the question is, what consideration for systemic treatment and what utility for PSMA PET? So if I ask my colleague, Dr. Barata, who's a medical oncologist and is seeing more and more of these patients as a medical oncologist working with urologists.
Right. No, thank you. That's Saad. Pleasure to be here. Thank you all for joining after a long day. Yeah, just to keep it brief, I think you touched on all the important points, right? I think I would argue most of us would be considering a PSMA PET scanning at this point. Far more sensitive than conventional scans. If for whatever reason we don't get access to it, this patient fits the bill for the EMBARK study. So definitely I'm thinking ADT, enzalutamide combination, that would be the default plan to go for patients who are facing mortality from prostate cancer, which will remind you is over 10 years in this setting, right? Now, it might be the case that if you get a PET and you see disease, how you address that. Some might philosophically say, you know what, if I see metastatic disease on PET, negative scans, I would still treat that patient as I would for ARCHES, although ARCHES metastatic hormone sensitive by conventional scans, so that would be a way to go, or by enzamet, if you will. Now, obviously, I don't think we can ignore the emergence of oligometastatic setting. A lot of these patients will find some disease, and the question is, should we incorporate local therapies and think of what type of systemic therapy we're going to do? Many of us are considering shorter durations of systemic therapy along with local therapy, usually SRS, radiosurgery, and that to me is the gray area. So I would argue negative scans fits the bill. It would be an EMBARK type patient, and to me would be offered ADTNs, or at least have that discussion, not forgetting that some selected individuals might be well appropriate for enzalutamide monotherapy. Both have shown, as you said, delayed or prolonged MFS compared to ADT alone. But that would be probably my choice, unless there's something different in the PET that would make me think of metastasis-directed therapy. What about you, Fred?
Yeah, no, I totally agree. I mean, this patient needs to be treated. Historically, we would have given this patient ADT alone. Intermittent or continuous, I think intermittent makes perfect sense in a patient who's non-metastatic. But now with the PSMA PET, we are doing, based on tumor board discussion, considering treating the sites of metastatic disease if they're amenable and can be done safely. And we've published recently a study showing that outcome is better when you intervene on the PSMA PET. So this is something that's important. But just a quick question. We know we have EMBARK. We know that was with enzalutamide. Would you consider that this is a class effect of an ARPI, or would you consider this has to be enzalutamide in this kind of a patient?
Right, that's a good question. I think for the most part, we try to be data-driven as much as possible. Now, of course, we take into consideration safety profile, drug-drug interactions. It might be the case that patient is on a different type of medication that would make me think twice around enzalutamide as a therapy choice, or even history of seizures, for example. So the consideration for another ARPI, for me, comes as a second option. I would think of enzalutamide as a go-to and think of another option to replace enzalutamide if I have a reason to do so.
Right. If you consider them non-metastatic.
Right.
But if you find metastatic disease, then all the ARPIs would be...
That would be appropriate, and to me, then it will be, as you said, the debate. So we always confirm if we see disease by PET and we're thinking of an MDT, metastasis-directed therapy, we always try to confirm with anatomic alterations, whether it's a CT or an MRI for the most part. For a lot of times, our radiation oncology teams don't feel comfortable treating imaging, functional alterations without anatomic changes. With that said, if I have a super high SUV, for example, in lymph nodes, even if they're not enlarged by RECIST criteria, we've actually offered SRS to lymph nodes in that setting. But for the most part, we try to confirm that by conventional imaging.
Perfect. So, next question. Based on what you just heard and what you know in your practice, what's your challenge with using PSMA PET? So we see the advantages, but I think repeatedly there are some challenges, and sometimes we don't even decide to do the PSMA PET. The patient comes in already having had a PSMA PET, and we have to deal with that result. So stage migration, interpretation of false positives, understanding how the results influence the treatment approach, or adequate access and logistics in actually getting a PSMA PET. So if you can take a minute and answer. Not a minute, a few seconds. Okay. So it seems to be the interpretation of false positive, this risk of over-treating and understanding how these results, and I think a little bit what Dr. Barata mentioned, that, are you going to treat them as a metastatic patient if they're only on PSMA or on non-metastatic high risk? I think those are things that have to be discussed in a setting with colleagues and try to do the best you can, but I wouldn't necessarily condemn a patient to lifelong ADT and ARPI because there were a couple of spots on a PSMA PET that was negative otherwise. So we'll continue now with Dr. Barata, who will cover some of the real-world evidence in MHSBC care.
Oh, perfect. Okay, wonderful overview, Dr. Saad. All right, so let's keep going. So one step further in the disease course, and we get to talk a little bit about metastatic hormone-sensitive disease. I will not use, by the way, PCW group 4 nomenclature, so I'll stick to PCW group 3. So I'll use the terms HSPC, if you will. And here's purposely a busy slide with how we've come to this point in the last decade, or over a decade now, quite frankly. First with docetaxel, first with different ARPIs, abiraterone 2017, enzalutamide, apalutamide 2019, then darolutamide with docetaxel with chemo. We call that triplet regimen with both abiraterone on piece 1 and darolutamide with Arisens. And that's kind of what we just actually at a meeting where ARISEC, the US cohort, was just presented with darolutamide ADT without chemo, as well as ARINOTE. We've seen that Dr. Saad did a great job being part of that study, darolutamide ADT as well, international effort. So the point of this table is not for us to memorize all hazard ratios, but to kind of look at what's in common. By intensifying the inhibition of the androgen pathway, we're able to control tumor in about, around or 40% or so. And in terms of overall survival, we have survival gains. Usually we summarize them about 25 to 30% risk reduction. So we are able to achieve significant success by moving these therapies, particularly RPIs, early on, with or without chemotherapy. Now, we know that in many cases, this disease is heterogeneous, and Once we found out that docetaxel was able to improve outcomes in this setting, ARPIs were able to improve outcomes in this setting, there's mainly 2 large phase 3 trials that ask the question around triplet compared to a doublet with docetaxel. So Piece 1 is a European effort, large study. You actually have more than one question being answered. I'm going to focus on the triple approach of ABI, docetaxel, ADT. And what you can see here is that the benefit seems to be a differential signal here by volume. And volume, we still use the term by Charted, 4 more lesions in the bone, spine and pelvis, 1 outside spine and pelvis, and or visual disease. The Stampede group defined that as burden, so high burden, high volume, and you can see it, the difference in signal, which tend to favor, triple therapy tend to favor those patients with high volume disease. At same token, we've looked at the combination of darolutamide with docetaxel, again, compared at the time what was the standard of care, ADT docetaxel. And what's interesting about this is, number one, we did see that improved survival there. I think the signal is pretty strong, 32% risk reduction favoring the triplet with darolutamide. And it's interesting because all the other endpoints were also superior for the triple therapy. You're looking at time to PSA progression, and you look at the breakdown by volume, and the signal seems to be present irrespective of volume. I will say this trial enrolled mainly high volume disease patients. I believe over 80% of them or so. And with that said, it established ADT, darolutamide, docetaxel as one of the standards in this setting. Now, with that said, it's interesting to look at the quality of survival, right? So one thing is we control the tumor, patients live longer, but do they live better or the same? Or by throwing the sink at them, are we going to have detriment in quality of life? And when you look at that data, here's a method called Q-twist. You basically see the different areas under the curve at different colors. Bottom line, you see that additional over 6 months or half a year without symptoms or toxicity, which kind of makes sense, right? Many of these patients do well, and so you delay progression, and by doing so, you delay problems that come as you have tumor progression with symptomatic disease, if you will. You see that relative gain in this method of 16% compared to the doublet ADT docetaxel, and so it basically is another way to look at how patients did on the study, which again favored triplet. So we really don't have an excuse. When we think that patient will benefit from triple regimen, we should absolutely think of that in clinical practice. Then we look at the breakdown for error note, because the next question is, since darolutamide is established with docetaxel, the question is, do we need docetaxel for many of these patients? So international study, ex-US, at the time, 2-to-1 randomization. The design was around tumor control, defined by RPFS. Dr. Saad did a great job showing us this data. Bottom line, we have significant improvement of tumor control. You look at about 18-19% absolute difference at the 2-year landmark analysis there for radiographic progression-free survival compared to ADT, which was at the time standard of care in the countries where the study was conducted. The next one is actually, you always ask the question around the other analysis or other factors that may play a role, right? We do care about cardiovascular disease, we care about our population, we care about other problems, other disorders, whether musculoskeletal system, GI system, etc. And you can see, basically, if you take the vertical line 1 as even, if you will, basically the dots with the line, that means the confidence interval, they all favor the combination of ADT darolutamide. So in other words, you do see that the benefit of darolutamide is persistent across subgroups, and so that is consistent with the overall signal that we've seen, right? And so after that, as I think it's known, darolutamide was the newer kid on the block, added to the number of options we have available in this space to treat patients with metastatic prostate cancer, without the need for considering docetaxel, if you will. Now, the other aspect is, okay, we are AUA 2026. I mentioned the international effort. What about patients in the US? So this ARASEC was a complement to the data that we've seen ex-US. At the point when it was conducted, it was AADT RPI was already standard of care. So what was done here was basically everybody was offered on study ADT Daro combined, and then we had an historical control to put things into perspective from a statistical point of view. And as you can see, 50% risk reduction, significant delay time to MCRPC, and as well as 70% reduction in tumor control, favoring the combination. I would argue this is not surprising, but it's reassuring, right, and perhaps confirmatory that what we're offering today, to patients in the U.S. is absolutely appropriate, and Reina did a great job, presenting this data at this meeting. So the other aspect have to do with, how much do we like PSA, how much we trust it, how much should we use it, right? So we've seen this for a long time. I remember data from Ma Hussein from Intermittent study, and then many other studies following, showing us that even though we all say PSA is not a surrogate for survival, which appears to be true, we do want PSA come down, right? We want that, providers want that, patients want that, and actually means something. It's actually prognostic. So you want your PSA to go to undetectable levels, which at the world level, we define that as less than 0.2, because not in some parts of the world, we do have access to ultrasensitive PSA. In some parts of the world, we don't. So 0.2 has been a common denominator, if you will. Patients who get there do better than patients who don't get there. And how often? What's the chance of you getting there? It's about up to 2/3 of patients are going to get there. It's what you're seeing with the studies that you get put together. Arisons with docetaxel, Arinote, darolutamide without chemo, and then Arches and Titan, you basically look at data with Enza and APA. So anti-androgens are able to get you there. Abiraterone can get you there, but it doesn't seem to get you there as much. It's in the 50 or so percent compared to the 60s, if you will, for the anti-androgens, if you will. Now, the other aspect, as we see these patients remain on therapy for a long time, often measured in years. So it's important to think of potentially adverse events, right? Things like fatigue, muscle loss, weight gain, hot flashes, night sweats, fatigue, bone loss, cardiovascular events, gynecomastia, breast tenderness, etc. And so there's a number of aspects that we need to take into consideration when we see these patients, right? Never forget the cardiovascular risk factors. Never forget about bone health. Don't forget about exercise and diet. Those are very important as well. Being proactive about that is extremely important in this setting. And of course, when we make sense of all these options, I can do ADT, ABI, I can do ADT, Enza, ADT, APA, ADT, Daro, and then triplets with ADT, ABI, docetaxel, ADT, Daro, docetaxel. Oh my God, I have many options. And many factors play into account when I'm deciding the therapy for the patients. Do I worry about high blood pressure? Do I worry about low potassium, hypokalemia? Do I care about LFT elevation? Does it matter? The chemotherapy-induced toxicity like neuropathy, fatigue, cytopenias, does it matter the IV administrations versus taking oral medication at home? Does it matter the cardiovascular risk factors? Probably does, right? So it's very important to understand the differences between what it is to use chemo versus ARPIs, and also some of the side effects are common to all of them, right? Very commonly we see fatigue, very commonly we see high blood pressure. In almost everybody we will see some degree of ADT-related adverse events. So there's some adverse events specific to some of the options that we go with, and others are basically common to the approach that we decide to go with. So in summary, intensification is standard of care for the vast majority of patients with metastatic disease. I would argue every time patients are facing mortality from prostate cancer, they should be offered treatment intensification. Triple therapy should absolutely be considered for selected patients, probably not for everybody, particularly synchronous disease, meaning patients who present with newly diagnosed disease, high volume disease. Prostate cancer is not one disease, it's many diseases. So we have heterogeneous disease from a biological perspective, and there's a number of factors that can help us decide how to treat. I didn't touch as much today on genomics, but that, PSA response, clinical characteristics, volume, time of disease, all of those matter. We want PSA to go undetectable levels, that is prognostic. And, and so it's important as we consider what to do and whether or not we need to do additional therapies or interventions needs to be validated in prospective studies. And we do have a number of studies trying to prove that point as we speak. And finally, genetic testing should be considered early. We haven't talked as much. Happy to discuss with Dr. Saad and the group here today around germline testing as well as somatic testing. All patients with metastatic disease should be considered for both testing. And it does matter how we treat these patients. And with that, I'm going to move quickly to a case. So we have a 64-year-old presented with lower urinary tract symptoms, very, very high PSA. Doctor suspects as prostate cancer, gets him a biopsy proving Gleason 9 disease there. And unfortunately, scans show disseminated bone metastasis. No question, this patient has high volume disease. You kind of see some borderline lymph nodes. They don't fit the bill for lymphadenopathy, but they're enlarged how it should be. So, Dr. Saad, let me ask you this. I'm sure you're seeing a patient like this at least once a week, if not more, probably more. What's your thought process? It can be quite complicated and comprehensive, your approach, but walk us through what you do at this point.
Well, we're not supposed to talk about age, but this patient is young. He's my age, so he's extremely young. I mean, patients of this age, I call them pediatric in my clinic. So we have to be very aggressive with these young patients that have a long life expectancy. So, we talk about age, but really we look at life expectancy. How many years can we hope for this patient? So, their history, what they're living with, can give us a good idea. And when patients are starting to have more than 10 years, and especially more than 15 years of life expectancy in a metastatic patient, we absolutely have to do what's right for the patient. So this kind of patient, and this is part of the shared decision, I would seriously talk about one, ADT and an ARPI is minimal standard of care. That is no question. That should not even be a discussion point. Then the question of adding chemotherapy or not, this is where the shared decision has to come in. And it absolutely has to be discussed. And if, as a urologist, we're not comfortable talking about chemotherapy with the patient, we have to have teams that help us so that this is at least discussed optimally so the patient can make the decision that's most appropriate. This should not exclude the urologist who made the diagnosis and who should be involved in the care of the patient until the end. That's a philosophy. But not talking about chemotherapy in this kind of patient, I think, is probably not appropriate. So to talk about it, and then after that, the decision is, I tell the patient, your decision is going to be the right decision. And let's not come back to that decision and have regret. Whatever you decide is going to be the right decision. And so this patient, I would probably favor, he's coming in with a high volume disease, Gleason 9, even worse if it's Gleason 10. Sometimes the PSA is underestimating the extent of the disease. And I actually look at other things. I look at alkaline phosphatase. I look at LDH. These kind of things. I look at symptoms. Patients who come in with symptoms have worse prognosis. These are all simple, non-costly things to be looking at to help us help the patient make the decisions most appropriate.
Would you consider genetic testing at this point?
Absolutely. So genetic testing at the time of diagnosis is the ideal moment. This is when patients need to know whether or not it changes what we're going to do today. And it's coming to be able to use PARP inhibitors in the hormone-sensitive setting. But even when we have to reserve them for castration resistance, knowing today what we might need to do later is important. And also because the quality of the tissue for somatic testing is at its very best early rather than 2 or 3 years later when it's sitting in formalin. And germline testing would have an impact on the patient's family. So if the somatic is positive, then we would go to germline. And these are all things that are maybe complicating our lives as urologists, but we have to make that effort for the patient. So I don't know what you think about genetic testing at this point.
Yeah, I agree. Just the AUA guidelines and as well as NCCN and actually all prostate cancer guidelines now bring up the topic of germline testing for localized high risk, recurrent metastatic disease. So that means genomic alterations you were born with, you got from mommy and daddy. They don't change. You do the test once. You should try to get a comprehensive test, not just look at BRCA, but a test that tests for other cancer-related genes. So that's one type of test that you can do. And then test the tumor. If you have tissue available, you can send it out to get NGS testing, they sequence the DNA, RNA, you get a comprehensive report. If you don't have tissue available, if you haven't started a patient on treatment with ADT, you can also do liquid biopsy. Basically, you find circulating tumor DNA, and you just sequence the DNA. You're going to get DNA alterations as well. I would encourage you to use NGS for that test. And if you do that, by the way, concordance rates is over 80% with tissue. So even if you have a role for a PARP, which we haven't touched on today, but it is approved as of December, we have a PARP with an ARPI. So to Dr. Saad's point, ADT RPI, if you're facing mortality from prostate cancer, is absolutely standard of care. The vast majority of your patients will not have BRCA. So the vast majority of your patients will be considered for ADT RPI with or without docetaxel. And then for those that for now, BRCA, where BRCA is available or testing is available, you could, even if you want to consider a PARP, then it would be a PARP combined also with the RPI. So I couldn't agree with you more, just sad. And then also matters and upon progression, how do you sequence those therapies also going to be another important aspect.
Excellent. I think we covered quite a bit. And so the next polling question is, which treatment regimen would you now recommend for this patient with high volume MHSBC? ADT monotherapy and PSA monitoring to introduce it later when they're castrate resistant, ADT plus ARPI upfront, ADT ARPI plus docetaxel, ADT plus docetaxel alone, whatever systemic therapy you decide, plus radiation to the prostate, or I'm not really sure. I'm getting a little confused. So if you can vote. Okay.
There we go.
Well, that was quite convincing. 2/3 would at least open that discussion to adding docetaxel to ADT and ARPI. I think I'm very happy that nobody voted for ADT monotherapy. I hope that, unfortunately, it's still going on, not as much as before, but
right.
What I tend to say is that PSA is our worst enemy. You start a patient on ADT, patient sees his ADT drop, say, why do you want to give me anything else? Everything's just perfect. And we have to explain to them that even if PSA drops tremendously, what we want is to drop it even further, but mainly to keep it down and to delay the eventual progression towards castration-resistant disease. Any other points that you wanted to make on this, Pedro?
No, this is great. We also didn't touch, so to be comprehensive, we didn't touch on the role of radiation to primary tumor. I mean, we could highlight a little bit of data on that. We have the Stampede data. But if I were to summarize the data out there, it appears to have a benefit in tumor control by offering radiation to primary tumor for patients who walk in the clinic with newly diagnosed disease. The benefit in overall survival has been shown, pre-specify ad hoc as part of the Stampede for patients with low volume disease. So some groups around the world do consider as part of their standard of care to offer radiation to primary tumor in addition to ADT ARPI combo. For patients with high volume disease, the benefit in tumor control has been demonstrated. We haven't seen a validated overall survival signal. There are some ongoing efforts to try to validate that, also with surgery incorporated. So I would say, I don't think it's wrong, but it is true that we've been being selective with the use of radiation for patients with a primary cancer, with primary tumor in the context of high volume disease, mainly for those who have symptomatic disease and need it for palliative purposes. And so I think the marginal votes there does reflect the practices around the world on that topic.
Right. So the role of radiation therapy, another discussion with colleagues and multidisciplinary approach. So here I'm tasked to discuss a little bit of castration resistance, and this is not the focus for most urologists, but I think for we have the responsibility of at least informing our patients that there are things that are available when they become castrate resistant. Unfortunately, things are much more complicated than they used to be. It's not enough to say that somebody is metastatic castration resistant anymore. You have to know what they got before becoming metastatic castration resistant. Historically, it was post-ADT alone, so it was pretty easy. It was ABI or ENZA or docetaxel. But now, many patients, based on what we just recently discussed, are going to be exposed to either an ARPI and docetaxel, and then the options change. It's not first line anymore, even though it's first line MCRPC. It becomes something that has to follow what they received in the past. And we talked about having a mutation, if they had a mutation without exposure to an ARPI versus with. So it's just to say we have to make an effort to know clearly what patients have had prior to becoming MCRPC to be able to decide what's the appropriate for that first line patient. And we have radiopharmaceuticals. We have alpha and beta emitting radiopharmaceuticals. The oldest that we've been using is radium-223. It was the first to show a survival advantage using a radiopharmaceutical in prostate cancer, and that's radium-223. And the advantage of an alpha is that it's very specific. It doesn't penetrate too much. Basically, a piece of paper will stop the penetration of an alpha particle. So very few hits to get cell kill, short penetration. So in theory, and this is in reality, very little effect to the bone marrow, and the type of DNA damage is oftentimes irreversible, difficult for the cell to repair. And now we're starting to develop other alpha-emitting agents like actinium. And then the beta is what's most known as the new generation radiopharmaceuticals, even though it's an old target, and that's the basis of lutetium, PSMA-617, that has less energy to the tumor, lower potency, longer penetration, so a little bit higher risk of getting into the bone marrow and causing some damage, and single-strand DNA breaks that are more likely to be repaired in patients. And so radium-223, I won't go through the whole history, but this was the first, and already 2013 published in the New England Journal and approved almost immediately after this publication, showing that adding radium to best standard of care at the time of the study significantly improved survival by a risk reduction of death of 30%, which was very statistically significant in very sick patients, mostly post-docetaxel, but some even prior to docetaxel if they were unable to get docetaxel. And here, what was interesting is you have both types of patients, and both benefited, whether or not they were exposed to docetaxel before getting radium. You have to remember, this is in an era where ARPIs were not yet available. So the question begs, now that we have ARPIs and we have radium, and we know that ARPIs are the first-line therapy, can we do better than first-line ARPI? And this was the basis of the PEACE-3 study that added radium to standard of care ARPI. In this case, it was enzalutamide. And so it was radium plus enzalutamide at the standard dose for MCRPC versus enzalutamide life-prolonging therapy for MCRPC. And it showed, to many people, this was a surprise, that we significantly delayed radiographic progression and more recently confirmed a clear risk reduction of death over and above enzalutamide, which is probably the most effective life-prolonging first-line therapy for MCRPC in patients, obviously, that don't harbor necessarily BRCA mutations. So this is improving over a standard of care. All the other MCRPC trials that got approvals were against a placebo. So this is improving over what would be considered one of the best standard of care. Now, this study also brought up something really interesting, was the importance of bone protective agents like zoledronic acid or denosumab in the MCRPC setting. And early on in the study, it was optional whether or not to use a bone protective agent. And what we realized in the study was that patients who got enzalutamide, radium, without a bone protective agent had about a 50% fracture rate at about 3 years. Even enzalutamide alone without a bone protective agent was about 30% fracture. But if you gave a bone protective agent with either of the randomization arms, there were almost no fractures over 3 years. So very important in MCRPC to consider, more than consider, recommend strongly to use a bone protective agent in these patients. So let's rethink our choice. Based on updated data from PEACE-3, would you now consider adding radium to enzalutamide for a patient with MCRPC who has bone metastases? Yes, but only in symptomatic patients with visceral metastases. Yes, for asymptomatic non-visceral metastatic patients. No, I would not intensify treatment, and I'm not really sure. So if you can vote. So while we're voting, I'll ask Pedro to start thinking of what he would do now, given these options.
Right. Yeah.
You can show the...
There we go.
Okay. So, what would you do, Pedro?
Yeah, so I agree here. So most patients, or most people, sorry, most of us would vote for non-visual mats consideration of ENZA radium 223. I'm with you. That said, I think that there is super strong academic effort, large effort in Europe, URTC driven study, really important effort. It really a message. I start using it again more in my clinics, and one would argue what happens to patients who have progressed on a prior ARPI, as the data was basically developed in the context of ARPI naive for the most part. Although I will say that I've considered this a little bit off-label for patients who have progressed post-abiraterone, and I wouldn't feel comfortable going cross back-to-back enzalutamide follow after abiraterone. But I have done it, to be fair, in a selected number of patients in combination. But the clean would be patients who get to CRPC, have been on ADT for years, develop metastatic disease, they have castration-resistant disease. To me, it is a no-brainer. The vast majority of the patients will not have genomic alterations, and therefore will be receiving ARPI. So my choice would be ARPI radium-223 in those cases. So I would stand with the other 54% of the room on this.
Right. I think the challenge is patients who are already exposed to an ARPI, you give them with the ARPI. But I think the bottom line, and what's been repeatedly shown, is that if you wait for patients to be very symptomatic, post-docetaxel, the impact is less. So after an ARPI, what we're doing now is in patients who have bone disease without visceral mets, we're considering always giving them radium as a treatment option that is fixed for 6 months and very easy to tolerate for patients.
Yeah.
So the other trials assessing radium now is exactly addressing the point that was brought up. So these are patients who have already failed one taxane regimen and one novel hormonal or ARPI with bone-dominant disease, looking at radium versus a switch in ARPI, and this is going to be reported soon. And a long-term results of REASSURE, looking at real-world characteristics, and what was seen is that more than a quarter of patients will live more than 2 years, and the biggest factor of living more than 2 years was able to get the full dose of radium. So really the timing is important to be able to get all 6 doses. This is radiation therapy given systemically, and we know that there's radiation accumulation, and the more radiation, the more likely you're going to benefit. So really timing is of the essence if we want to get the maximum benefit. Now, switching gears to lutetium, which is the radiopharmaceutical that has revolutionized, because patients and physicians love the concept of being able to target cells that we see based on PET imaging with PSMA. And in the very late stage disease, post-docetaxel, post-ARPI, and even sometimes post-chemotherapy of other sorts, there was an improvement in overall survival, an improvement of radiographic progression-free survival with lutetium over standard of care, which excluded chemo. So basically, against best supportive care in these patients. But now we have some data that helps you to figure out whether or not patients are going to benefit or are benefiting from lutetium. This is data that I presented at the AUA a couple of years ago and was now published, looking at rPFS and OS based on PSA decline after only 2 cycles of lutetium. So if PSA is not going down by at least 50%, there is probably little benefit in continuing the agent. If there are other options, you need to strongly consider maybe looking at another option if they haven't been exposed to chemotherapy. So obviously this is the post-chemo setting, so we need to strongly consider whether or not we should continue. And if they're not going down at all, this is really dismal. They're progressing in about 6 months and unfortunately dying in about a year. So your amount of time to act is low. And we are doing work in post-lutetium patients or lutetium-resistant patients with new generation radioligand therapy. Now, PSMA4 took the concept of lutetium prior to docetaxel and showed that you can get a significant improvement in rPFS compared to a switch in ARPI, and that you were able to significantly delay symptoms and preserve quality of life. So this is interesting and now approved in the States in the taxane-naive patient. So basically the choice is chemotherapy or lutetium post-ARPI. Now, the field has exploded with radiopharmaceuticals. There are multiple trials ongoing and starting with novel agents of all sorts, whether they're beta-emitting agents or alpha-emitting agents. It's really an exciting field and one of the forays into precision medicine. And just one example of a phase 1 study that we're doing that was presented at ASCO GU a couple of months ago. So this is a phase 1 dose escalation study in the very late stage, post-ARPI, post-taxane, but look at the kind of responses we're getting with an actinium-based compound. So 83% PSA response with the 125 dose, which is the dose we're likely to move forward with in phase 3, and overall response, measurable response rates of 70%. This is something that we've rarely seen in this late line setting, and this is just one example of a patient after 2 cycles of this actinium-based compound. Look at the metastatic burden at screening, and after 2 cycles, almost complete disappearance with PSA plummeting to undetectable and staying that way. And the first patient ever treated on this trial with the lowest dose is still in complete response in my clinic for over 2.5 years now with 0 PSA and no evidence of disease. So implementing radioligand therapy is easier said than done. There's a lot of things that have to be set up. It's probably not going to be able to be offered in every clinic because it's a little bit complicated with licensing and equipment, but it is possible and needs to be offered to patients that are appropriate to get this. And the logistics around this need to be discussed with your centers and centers with which you collaborate. So let's end with this patient who has had ADT, docetaxel, abiraterone for MHSPC with multiple bone mets. He responded well at the beginning and then was maintained on abiraterone and ADT and completed the docetaxel obviously after 6 cycles. 4 years later, now he's progressing. New bone lesions, elevated alkaline phosphatase, rising PSA, no genomic alterations. Now he has bone-predominant disease. What would you discuss with this patient, Pedro?
Yeah, no, it's great, great case to illustrate your tour de force going through the data that's relevant. I think, I won't mention as much docetaxel rechallenge since it's happening 4 years later. There's arguably good data out there around the rechallenge. I think chemotherapy needs to be considered. We have data with cabazitaxel, although it's not exactly how it was studied, right, on the CART study, slightly different from this patient, but we could use cabazitaxel. We have therapy comparing cabazitaxel to lutetium PSMA, which would be in the post-docetaxel setting. So this would be a vision-eligible patient, if you will. So lutetium PSMA would definitely be a consideration. I'm not sure in today's world we would be thinking of radium-223 by itself as monotherapy, so it probably wouldn't be my top option. I probably would be debating between chemotherapy and lutetium PSMA outside, of course, a clinical trial, keeping in mind this patient has genetic testing, and it doesn't open the door to any targeted based approach, if you will. So I think those are probably at the top of line as options for him.
Yeah. Well, this is not the run-of-the-mill kind of patient for the average urology in private practice, but these are the patients we do see. And having these options, I think, is what's most important, that we have options. Now, if the patient refuses chemotherapy, radium is an option. If you can get lutetium, clearly this patient has already been exposed to docetaxel. But in the ideal world, patients should get both or all three. Should, if they're healthy 70-year-old, go through cabazitaxel, radium-223, lutetium, whatever order. What's important is that patients get access to as many lines of therapy before dying of prostate cancer, because we're not going to cure this patient. But sometimes we hit the jackpot and they go into remission again for a long time.
Mm-hmm.
So that ends what we had to say, but now we want to hear what you would have to say in the last few minutes. We left a few minutes for questions, if there are questions from the audience. We have a few online questions, but feel free if you've got questions to type in. So the first question that came in is, how long can treatment with an ARPI be continued for prostate cancer post-radiation with local spread to one lymph node Gleason 8 disease?
Yeah, so I'm trying to interpret the question. I think, so we're talking, let's assume biochemical recurrence, you get a PET, you find oligometastatic disease. This would scream MDT approach. It's very debatable. We don't have level 1 evidence. Some would argue stage 4 disease. I'm going to offer ADT-RPI continuously, indefinitely, right? Patient with recurrent low volume tends to be on these therapies for years, many, many years. They have the best outcomes. If you want to explore MDT, if you're going to use SRS, most of us are doing a limited amount between 6 months to 2 years. Some would do salvage, and then they use get-to data to do 6 months of ADT with SRS. Others will be more intense and treat like they would treat localized high risk by offer 2 years of ADT-RPI along with SRS and then stop. I think most of us are thinking about stopping to prove the point. Were we able to cure the disease in the context of oligometastatic disease? I will just finish by saying, in most cases, we're not able to offer cure, but we are able to offer long remissions.
Yeah, absolutely. This wouldn't be considered a metastatic patient if it's pelvic lymph node. So I think you try to target it if it's safe and giving them a fixed amount of time and then trying to get them off systemic therapy. So the other question is, urology and oncology clinics need to coordinate to support shared patients across the disease continuum. So this is a big question. How, what are the tips and to getting infrastructure to be able to support these patients?
Yeah. So I mean,
what are you doing in your center? It's obviously a referral center.
Right. So we have those groups there. We meet on a regular basis every week. So that's easier, perhaps, for an academic center to make those meetings. And we open it up to the community to join us and discuss those cases. I think there's an effort, recognized effort in the US, at least for the groups that are outside academic centers, to try to create these kind of centers of excellence where you're trying to get access to it. A lot of times our pharma sponsors help us with connecting and with that networking. So, if you don't have all the services available to you right there, but you can find out who is in the region who can help you, because not in all geographic locations, you'll have all specialties available to you. So I do think it's very regional dependent.
Yeah, no, absolutely. And I think reaching out is the first step. I think everybody wants the patient to be the center of their priorities. So reaching out, I think you'd be surprised that there is not going to be much reluctance in working together and creating this kind of virtual tumor board. If you don't have a center that has a tumor board, is really important to be able to streamline patient care. You know, there was there were questions about access to PSMA. I think that's something that is hard to really solve in one session. How long treatment to be continued after RT, Gleason score 8, locally invasive PSA down to 0? So how long the treatment should be continued? I think that is, you know, for high-risk patients, 3 years of ADT was always the standard. We've realized that 18 months is probably sufficient. It was non-inferior to 36 months, but I think that's really a discussion based on the patient characteristics and just how high risk they were. If they're very high risk, we would probably intensify in those patients.
Yeah, I have the same practice. There's just recent data meta-analysis out of NRG, Nick Zorsky and colleagues, and you know, we were part of that, but came on JAMA Oncology and suggesting that most of the benefit happens in the first year and kind of drops. But I would argue, yeah, definitely over a year is what I do as well in my practice.
Yeah, absolutely. And then just to end, you know, this question of, are there differences in the length of treatment between the ARPIs? There's not really any difference. I think it's all the same length of, it depends really on who you're treating. And for MHSBC, the standard of care for now is still lifelong ADT and ARPI. We're working on trials in patients who get these exceptionally good responses of trying to stop treatment. And that leads to this last question, are we doing trials without ADT? I think that's what patients would really appreciate. I don't know if you've got any.
That's a number of studies. The cooperative group is looking into that. Pharma sponsors are looking into that. They're looking two things. One, dropping the ADT and continuing RPI, and others dropping both, right? And you're right. For, you know, looking at exceptional responders is probably seems like the low-hanging fruit is going to be. I think we're going to see that data, you know, I do believe it's an important question, and we'll have that answer. I think we got to wait probably another couple of years at least to see those results, but we're going to be having that data.
Yeah. So I think what you've heard is that if you think things are complicated, you're probably correct. They are complicated, but it's in the best interest of our patients. And so we leave you with this word from Zero for patient advocacy to be able to get information in communicating to our patients so that they can understand what we sometimes have a hard time totally grasping with. It's a huge effort and a huge amount of information. And so you can just imagine for patients what this is like. So with that, I'd like to say thank you very much for having been here tonight. You can send your evaluation and claim credits for the activity, and stay tuned for the online activity that's going to be based on this event. So thank you very much.
Thank you.